Welcome to The Explainer. Today, we're going to be unmasking a major global health threat, one that often strikes completely without warning: the pulmonary embolism, or as it's often called, APE.
Okay, so let's just dive right into it with a pretty startling fact. A pulmonary embolism isn't some rare, out-there condition. Nope, it's actually the third most frequent cause of cardiovascular death in the entire world, right behind heart attacks and strokes. So yeah, that puts it way up there on the list of major killers.
Now, what's really fascinating here is just how dramatic the difference in survival is. For stable patients who get diagnosed fast, the risk is tiny. We're talking less than 2%. But for high-risk patients, it kills about 1 in 5. And if that PE causes a cardiac arrest, well, the mortality rate is over 95%. It's almost a death sentence. This really shows you it isn't just a diagnosis, it's an absolute race against time.
So, where does this silent killer actually come from? Well, you might be surprised to learn that the story almost never begins in the lungs at all. The whole journey starts right here, with something called a deep vein thrombosis, or DVT. This is basically a blood clot that forms in the deep veins, and it's usually in the legs. You can think of it like a ticking time bomb, because somewhere between 70 and 90% of the time, a piece of that clot breaks free, travels all the way through the bloodstream, and bam, it gets stuck in the lungs. And that's what causes the PE. And this slide does a brilliant job of explaining why these clots even form in the first place. It's this concept from way back in the 1800s that's still totally central to medicine today. It's called Virchow's triad. You kind of need this perfect storm of 3 things to happen: venous stasis, which is just sluggish blood flow; endothelial injury, which means damage to the vein wall; and hypercoagulability, where the blood itself is just more likely to clot. So then doctors take all those risk factors and they group them into 2 main buckets. Are they transient, temporary, like from a recent major surgery or maybe a long flight? Or are they persistent, like an ongoing battle with cancer? And making this distinction is absolutely critical, because it helps predict the risk of another clot forming down the road, and it guides how long a person is going to need treatment.
Okay, let's move on to the main event. Let's see how this whole thing builds into a life-threatening crisis once that traveling clot finally makes it to the lungs.
So, here's the crucial point, the real heart of the matter. The right side of your heart, the right ventricle, it's a thin-walled, low-pressure kind of chamber. Its job is to gently pump blood into the lungs, which are super flexible. It is simply not designed to slam blood up against a sudden, massive blockage. It's kind of like a sleepy little country road suddenly having to handle all the rush hour traffic from a 6-lane freeway. It just gets overwhelmed.
And that mismatch, it triggers this catastrophic 4-step chain reaction. First, the right ventricle stretches way out, or dilates, as it struggles against all that pressure. Second, that stretching increases the tension on its walls, and it cuts off its own oxygen supply. That's a condition called ischemia. Third, the now swollen RV actually bulges into the left ventricle, literally crushing it so it can't fill up with blood properly. And then fourth, the whole system just fails, and that leads to circulatory collapse and shock.
Given how deadly this whole process is, you'd think it would be super obvious, right? Easy to spot. But the reality is the exact opposite. So why is a PE so darn hard to diagnose?
It's because PE has earned this really notorious nickname in medicine, the Great Masquerader. It is a master of disguise. Its signs and symptoms can look like dozens of other, much less deadly conditions.
I mean, think about the symptoms. The most common one is shortness of breath. That happens in over 80% of cases. But what doesn't cause shortness of breath, right? Chest pain, a fast heart rate, even fainting. These are all incredibly common complaints in any emergency room, and they could point to anything from a panic attack to a heart attack.
So, to cut through all that diagnostic noise, clinicians don't just guess. They use these validated scoring systems, like the Welsh criteria you see here. And by giving points for specific signs and symptoms and risk factors, they can systematically figure out the probability. Is it low, moderate, or high that a patient actually has a PE? And that calculation then guides the next steps for testing. And when that suspicion gets high enough, this is the definitive test. It's called a CT pulmonary angiography, or a CTPA. It's a special type of CT scan that uses dye, and it lets doctors literally see the clot inside the arteries of the lungs. This is the gold standard for diagnosis. All right, let's switch gears to some good news. Let's look at how modern medicine is fighting back against this killer once it's been found.
we've got a pretty powerful and growing arsenal of treatments. The approach really gets tailored to the patient and how bad the clot is. It can range from medications that just prevent new clots to powerful clotbuster drugs that dissolve the ones that are already there, all the way to advanced catheter procedures and even open-heart surgery to physically yank the clot out.
Now, the foundation for pretty much all PE treatment is anticoagulation, blood thinners. And this field has been totally revolutionized. The older drugs like warfarin, they worked, but they required constant blood tests and monitoring. The newer drugs, called direct oral anticoagulants, or DOACs, they're now the first choice because they're just as effective, they have a lower risk of serious bleeding, and they don't need any routine monitoring. A real game changer.
And this is the real cutting edge of treatment. For patients who are sicker, we can now go way beyond just medication. There was a landmark trial called Peerless that just recently confirmed that using a device to go in and physically suction the clot out, a procedure called mechanical thrombectomy, well, it leads to faster and better results for a lot of these intermediate and high-risk patients.
So after all of this, after we've looked at where it comes from, its deadly potential, and all the modern ways we have to fight it, what's the one thing, the single most important lesson that we should all take away from the danger of a pulmonary embolism?
The crucial point really is this. For both patients and doctors, the most important weapon we have is a high index of suspicion. It's about remembering that these really common, everyday symptoms can be hiding a truly deadly cause. And once a PE is even suspected or confirmed, every single action has to be laser-focused on one goal: protecting that vulnerable right ventricle from its vicious cycle of failure. That is the key to unmasking and to defeating this silent killer.